Hello everyone, I am RD Anisa, MBBS student from Nepal Medical College, and I would like to invite you in my lecture on chronic renal failure. So we have already discussed about acute renal failure, and we have also discussed on acute tubular necrosis in our previous video. So now this is the time to study about chronic renal failure, and it is very important because chronic renal failure can manifest with several clinical features and along with several clinical complications, and that we'll be knowing in a bit. So as we have already discussed, renal failure means there has to be decrease in the renal function. The renal function is decreased in a sense that there is severe compromise in the renal filtration, and because of this, that will manifest with azotemia, and not just azotemia, it will also manifest with oliguria, that is less than 400 ml of urine per day, and azotemia means increase in the blood urea nitrogen along with increase in the creatinine level. And as there will be azotemia and oliguria, so this must happen and this should persist for at least 3 months, and then this will be considered as chronic renal failure. So chronic renal failure can also progress to end stage kidney failure when the renal function has been severely compromised and the filtration that happens in the kidney is about 5% or even less than 5% of what it is normally seen. So when the filtration is less than 5% of the normal GFR, then that condition is known as ESRD. So that is also known as end-stage renal disease. So let's begin our video with chronic renal failure. So chronic renal failure is nowadays, it is considered with a new name, and that is known as chronic kidney disease. And the definition of chronic renal failure is as follows. So it says that there should be azotemia for more than 3 month period with or without kidney damage. So with or without visible kidney damage. So there should be a term visible kidney damage. So how do we define chronic kidney disease? It is defined as azotemia, which lasts for more than 3 months, and there might or might not be any visible kidney damage. Or it can also be defined by the next mechanism, and the next mechanism is that there should be decrease in the GFR in a sense that the GFR is less than 60 ml per minute in a standard person having a body surface area of about 1.73 square meter. And this should also last for more than 3 months with or without kidney damage. So if any of this definition if suits the clinical features, then that condition will be known as chronic kidney disease. And mind you, the fact that there may or may not be a visible form of kidney damage in case of chronic kidney disease. Whereas the clinical manifestation will be, as we have already discussed in the point number 1 as well as point number 2. So the normal GFR that seems to be in our day-to-day life is about 125 ml per minute in a person having a body surface area about 1.73 square meters, and it is 10% less for women, and it varies with age, and with age that there will be decrease in the GFR, and but it should be greater than 90 ml per minute. So it should be greater than 90 ml per minute. If less than 90 ml per minute, then it will be considered as a form of decreased or compromised renal function. And if it is lasting for more than 3 months, then that will be a form of chronic kidney disease. So as I've already discussed, the term end-stage renal disease, it is just a severe form of renal disease where the GFR is less than 5% of normal. So the normal GFR, as I've already discussed, is 125 ml per minute, and in case of end-stage renal disease, it is about 5%. That is 5 out of 100 into 12. So it is approximately about 6 ml per minute. It is a rough estimate. So if GFR is less than 6 ml per minute, then that condition, there has been a severe compromise in the renal function, and this condition is known as end-stage renal disease. And there is the only method of treatment in this disease is the kidney transplantation, and the way of managing the patient is via dialysis for the survival. And the only thing that can be done in this disease is kidney transplantation, and it is very important point to know. So as I've already discussed, there are different stages of chronic kidney disease. So as I've already said in the last part of my lecture, or last slide that I've said, is more than 90 ml per minute is considered normal, or even more than 90 should be considered normal. When the GFR is about 60 to 89 ml per minute, then it is considered as the stage 2 damage with a mild damage or mild decrease in the GFR. when it has been decreased, so divide by 2. So when we consider it, so if it is about 30 to 59 ml per minute, then that is considered as moderately decreased in GFR, and this is called as stage 3 of chronic kidney disease. And if it happens to be again divide by 2, if it happens to be 15 to 29, then it is considered as a severe compromise in the renal function, severe compromise in the GFR, and that is the stage 4. And if it happens to be less than 15, then that condition is known as kidney failure. And if it is less than 6 or 7, then that condition is known as end stage renal disease. And in both the condition, to manage the patient, the only way of management is dialysis, and the only way of treatment, the definitive treatment, is a renal transplant. So these are the different stages of chronic kidney disease. So let us discuss about different causes of chronic kidney disease and different causes of end stage renal disease. So as we know that if the chronic kidney disease will exist for a long period of time, and not just for a long period of time, if the damage to the kidney will persist, and that may manifest with severely compromised GFR. If it happens to be less than 5% of normal, then that condition will result into end stage renal disease. So what are the different causes of chronic renal failure? So one of the reasons that I would like to talk is about acute renal failure or acute kidney injury that we have discussed in the previous part of our videos. So if there is chronic and persistent repeated attacks of acute kidney failure or acute renal acute kidney injury, then this may also manifest with chronic kidney disease. Not just that, there can be damage to the kidney, in a sense that the damage to the kidney happens in the form of polycystic kidney disease and even in form of glomerulonephritis. So as I've already discussed, the first cause that I have discussed was previous episode of acute renal failure, and this can be repeated time and again, and that will result into a chronic renal failure. The next cause that we are discussing is about kidney diseases, and one of the disease that we associate with chronic renal failure is polycystic kidney disease and glomerulonephritis. So as we have already discussed on videos on glomerulonephritis, that whenever the glomerulonephritis will exist for a long period of time, for a chronic period of time, what will happen is that for a long period of time, there will be accumulation of the growth factors, and this accumulation of the growth factors, along with the degree of inflammation, that will result into the rupture of glomerular basement membrane or even damage to the GBM, and that will manifest with increase in the proliferation due to the growth factor, and this increased proliferation will occupy the Bowman space, and because of the occupying the Bowman space, that will result into decrease in the GFR, and this decrease in the GFR, if it persists for more than 3 months, then that condition will result into chronic renal failure. So regarding the polycystic kidney disease, I will be making a video on that. But let me clear a fact on polycystic kidney disease is that the polycystic kidney disease, PKD, it can be autosomal dominant variant of polycystic kidney disease, or it can be autosomal recessive form of polycystic kidney disease. So whether it be dominant or whether it be recessive, in both the disease, what happens is that there will be lack of communication between the excretory part and the collecting part of the kidney. So excretory part of the kidney represents the nephron, especially the PCT, the descending limb, the ascending limb, the thick ascending limb of loop of Henle, and the distal tubule, which is responsible for formation of the filter, and the filter is eventually being collected in the collecting part, and that is our collecting duct and the renal pelvis and other structure with the ureter. If there is a lack of communication between the excretory part and the collecting part, so what happens is that in this condition, the filter that is formed is not being able to expel into the urine appropriately, hence manifesting with multiple cysts in the kidney, and these multiple cysts in the kidney can appear in the cortex as well as it can appear in the medulla, and with long period of time, that may also result into inflammation of the tubules, not just inflammation, and this itself disease, the formation of a cyst in the kidney will compromise the function of the kidney, because in the kidney the numerous nephrons are converted into epithelial line cyst, and because of this there will be decreased amount of the functional nephrons, and as the functional nephrons is decreased, there will be decrease in the GFR, and this decrease in the GFR will manifest with chronic kidney disease if it persists for a long period of time. And that is something about polycystic kidney disease. There is a lot to cover in this topic, so I'll be probably making a new video on that as well. So the next thing that I would like to discuss is about analgesic nephropathy, and analgesic nephropathy that I've already discussed in the last video. So whenever let us see this diagram of a kidney, and we can appreciate the kidney, the cortex part of the kidney. So let me change the color. So we can appreciate the cortex part of the kidney. We can also appreciate the medulla part of the kidney. So as we can see that the blood flow to the cortex is very much high, whereas the blood flow to the medulla, so the medullary blood flow is very less. And as we know, medulla can be divided into outer medulla and inner medulla. Especially the outer medulla is very susceptible to ischemia, as we have discussed in last video, because the outer medulla has high oxygen demand, whereas it has less oxygen oxygen flow. So if there will be even less degree of ischemia, and that will manifest with necrosis in the segment, that is outer medullary segment. So what we should know about analgesic nephropathy is that, so before that, let me tell you one more thing is that in the kidney, the blood flow is maintained via, it is coming via the afferent arteriole, and this afferent arteriole, the lumen of this afferent arteriole is dilated via prostaglandin, especially prostaglandin I2 and E2. And this prostaglandin is responsible for vasodilatation. And if there will be vasodilatation, this will result into more blood flow into the kidney, and eventually the blood will overcome the demand and hence prevent the necrosis. But what happens in case of analgesic nephropathy is that there will be increased abuse or increased chronic use of analgesics like NSAIDs, and that will result into inhibition of an enzyme that is known as COX enzyme. And due to inhibition of COX enzyme, that will manifest with decreased synthesis of prostaglandin. As the prostaglandin is decreased, the afferent arteriole are constricted, and as the afferent arteriole are constricted, there will be decreased oxygen supply to the part of the kidney, and that will manifest with damage to the tubules, and eventually for a chronic period of time that will result into analgesic nephropathy. So as I've already said, in the medulla, the blood flow is especially given via the vasa recta, and at the tips of the medulla, there is very less amount of blood flow. And if there will be slight degree of ischemia due to decreased amount of prostaglandin, because prostaglandin will regulate the lumen of afferent arteriole. If there is lumen of afferent arteriole is compromised, then what happens is that the renal papillary necrosis will occur, because at the tip of papilla there was already decreased blood flow, and you are more compromising the blood flow, and that will result into medullary ischemia. This is due to suppression of the prostaglandin synthesis that happens with the use of analgesic, and that use of analgesic for many years as well. So the next cause is about systemic diseases, and it is the matter of fact to know that the most common cause of the end stage renal disease, so the most common cause of end stage renal disease, it happens to be diabetes, and it is followed by hypertension next. So the systemic disease involving the kidney are very important, and the third most common cause remains the glomerular causes as well. So the first most common cause leading to chronic kidney disease happens to be diabetes, and it is followed by hypertension, and it is followed by glomerular diseases. So as we know, diabetes will also result into chronic period of hyperglycemia, and this hyperglycemia will result into formation of advanced glycation end product, and this is non-enzymatic glycosylation product that will especially deposit in the afferent arteriole as well as afferent arteriole, and that will decrease the lumen of the blood vessel. If the lumen of the blood vessel is decreased, this will manifest with decrease in the GFR. Along with that, what happens in the kidney is that there will be diffuse and even nodular glomerulosclerosis, and because of the diffuse and nodular glomerulosclerosis, it will result into microalbuminuria, and with period of time it may also result into macroalbuminuria. And along with the time, as there has been sclerosis to the glomeruli, along with decrease in the capillary of the afferent and the efferent arteriole, the lumen has been compromised, and this will result into decrease in the GFR, and this will also manifest with chronic kidney disease. So the next thing that I would like to talk about is hypertension. So as we know that hypertension can be of two types. It can be hypertension can be benign hypertension, and it can be malignant hypertension. So malignant hypertension, it is a severe form of hypertension that we associate when when the blood pressure is about, it is more than 200 mm of Hg. And the benign hypertension, it is a condition that we usually manifest also with old age. That can also happen in case of patient with diabetes, and it can also happen in patient with long-term hypertension, and that is not so severe, but that is also associated with arteriosclerosis as well. So whenever we are talking about hypertension, so if we are associating any diseases of blood vessels, so the diseases of blood vessel will eventually involve the kidney. And even the and even whenever the function of the kidney will be compromised, this will also involve the blood vessel. So let me explain this. Whenever the blood vessel is damaged in case of hypertension, like it can be hypertension in the form of malignant or benign hypertension. So as I said, in case of benign hypertension or arteriolosclerosis, it will result into benign nephrosclerosis. So it will result into benign nephrosclerosis, and that will result into formation of hyalinization of the capillary. So that will result into hyalinization of capillary, as a result of which the lumen of the capillary will be decreased. So this is a capillary lumen, and in the tunica media we can appreciate several hyaline like deposit, which is especially made of the plasma protein, and eventually the lumen has been compromised. Or whether you can talk in case of malignant hypertension. So in malignant hypertension there will be a condition that is known as malignant nephrosclerosis, and in malignant nephrosclerosis what you see is that there will be deposition of the fibrin and smooth muscle in an onion like skin manner, and eventually this will also compromise the lumen, and eventually that will decrease the blood flow to the kidney. As the blood flow to the kidney is damaged, this will manifest with certain damage in the tubules and even damage to the glomeruli, as we have already discussed in our previous part of the lectures. But what happens is that even due to compromise in the blood flow to the kidney, so kidney will also activate renin-angiotensin-aldosterone system, and that will further aggravate hypertension, and that will further lead to damage to the blood vessel. So there is a vice versa relationship between the blood vessel injury and the kidney injury, and that is also to be known, and that is also very high yield point as well. So hypertension is the second most common cause, as I've already discussed, and it can result due to hyaline arterial sclerosis, or it can also be due to malignant hypertension as well. So regarding the benign nephrosclerosis and malignant nephrosclerosis, so let me, so why to make a new video on that? It is a very small topic, so let me discuss it right now. So most of the portion I have already discussed on benign and malignant nephrosclerosis. So benign nephrosclerosis and malignant nephrosclerosis. So in what condition do we appreciate benign nephrosclerosis? So as I've already said, it can be appreciated in case of benign hypertension. It can also be seen in condition like old age. In old age, we can appreciate the thickening of the arterial walls, and that is known as arteriolosclerosis. Not just that, it can also be appreciated in diabetes mellitus, as I just explained, due to formation of advanced glycogen end product, and that will result into diffuse thickening of the glomeruli, the basement membrane, and that will manifest with benign hypertension, and this benign hypertension will result into benign nephrosclerosis. Whereas malignant nephrosclerosis, it is associated with malignant hypertension. So it is associated with malignant hypertension. So this is the condition that we associate. So what is the gross appearance of the kidney that we appreciate in benign versus malignant? So in the benign nephrosclerosis, as there has been compromise in the blood flow to the kidney, so the surface of the kidney will appear like leather grain appearance. So the surface of the kidney will look like leather grain appearance, because rather than appearance. So whereas in case of malignant nephrosclerosis, we can appreciate a severe form of hypertension. So that will result into rupture of the blood vessels, and as the blood vessels are ruptured, this ruptured blood vessel will result into pinpoint petechial hemorrhage, and this pinpoint petechial hemorrhage will result into kidney having multiple hemorrhagic spots, and this type of kidney is known as flea-bitten kidney. So it is known as flea-bitten kidney. So the appearance is this sort of, and so activity of renin-angiotensin aldosterone system will be absolutely normal in case of benign, whereas as we have already discussed, there has been severe compromise in the renal blood flow due to hypertension, and because of this, the kidney will try to compensate and will try to manage the GFR, and it will try to do so by activating renin-angiotensin aldosterone system. So this will aggravate the hypertension even more. So also the next thing is that proteinuria can be appreciated in case of both the condition, but the proteinuria is mild in case of benign disease, whereas in malignant there is marked proteinuria. So there is a marked proteinuria, and the next thing is that the sign of malignant hypertension is absent in benign nephrosclerosis, whereas of course, as I have said, it is due to malignant hypertension. So the sign of malignant hypertension is present, and the sign is like retinopathy and encephalopathy. So the sign of malignant hypertension, like retinopathy and encephalopathy, it is present in case of malignant hypertension. And the renal failure, so because of all this fact, now we can easily suspect that the renal failure, it will be less common in benign nephrosclerosis, whereas it will be more common in malignant nephrosclerosis. So it is also so these are all about the clinical features, the gross features that we appreciate, the differences between benign and malignant nephrosclerosis as well. So in microscopy, as I've already said, in microscopy, what you appreciate in benign nephrosclerosis is that there will be narrowing of the lumen. So the lumen, let's say this was the lumen, now the lumen has narrowed. And why the lumen has narrowed? It is because of the fact that as due to persistent hypertension, so the endothelial lining, there has been some degree of the gap in the endothelial lining, and through this gap of the endothelial lining, the plasma protein will leak into the smooth muscles. So let us consider this is our smooth muscle. So the plasma protein will leak into the smooth muscle, and this will result into hyaline-like deposit in the tunica media of the blood vessels. So this will result into hyaline-like deposit in the tunica media of the blood vessels, and because of this, the lumen has been compromised. And this type of hyperplasia is known as fibroelastic hyperplasia of the arteries and the arterioles, and this is also known as hyaline arteriolar sclerosis. So this is condition is also known as hyaline arteriolar sclerosis, and that will be associating with benign hypertension. And why does it happen? Because there is leakage of the plasma protein from the tunica intima into the tunica media, and hence deposited into the tunica media. So the next fact is that we can, in case of malignant nephrosclerosis, there has been severe hypertension. So because of that, there is severe stress on the blood vessels. So because of this, what happens is that there will be deposition of the fibrous tissue along with the muscle tissue. So fibrous tissue along with muscle tissue in onion-like fashion, and this will result into hyperplastic arteriolitis, that is onion skinning appearance, due to proliferation and elongation of the smooth muscle component along with the fibrous tissue, and that will result into decrease compromise in the lumen of the blood vessels. Not just that, it can also result into necrosis and foci of fibrinoid necrosis in the blood vessels, and that is also known as necrotizing arteriolitis. So there can be foci of necrosis in these blood vessels, and that will result into a necrotizing arteriolitis. And this is all about the benign versus malignant nephrosclerosis that I discussed with you in this video. So but the video is not about that. We are discussing about chronic kidney disease, and as I've already said, one of the very important cause of chronic kidney disease is it is the diabetes mellitus. And because of diabetes mellitus, there will be glomerular sclerosis, and we can appreciate all this sclerosis in the glomeruli. We can see this pink eosinophilic deposit in the glomeruli with the thickening of the basement membrane can be appreciated in this diagram. And in the periphery of the diagram, we can appreciate a pass positive nodule. Although this is not a pass positive state, we can appreciate this nodule, and this nodule is characteristic for diabetes, and this nodule is known as Kemal-Steele Wilson nodule. Wilson nodule. So this is also about the glomerular sclerosis that we appreciate in case of diabetes. So these are various causes that will lead to chronic kidney disease or chronic renal failure. So what are the clinical features that we associate with chronic kidney disease or chronic renal failure? So we have discussed a lot of causes, and due to the individual causes, there can be several clinical features. But the common clinical feature that we will be seeing in every form of kidney disease, every pattern of injury leading to kidney disease will be discussed here. So we are now discussing about on the clinical feature. So as we already know that there has been severe compromise in the GFR, and because of the decrease in GFR, it will result into increased level of blood urea nitrogen and creatinine in the blood. And this will, whenever the level of BUN to creatinine is increased in the blood for a chronic period of time, and it will manifest with symptoms of chronic renal disease, and this condition plus clinical features, and this condition is known as uremia. So what we'll appreciate is uremia. So what are the different features that we associate with uremia? So as I've already said, there is increased level of nitrogenous waste product in the blood, and that nitrogenous waste product will result in the blood will manifest with nausea. It will manifest with nausea. It will manifest with anorexia. Not just that, this nitrogenous product like urea, creatinine, it will get deposited into the pericardium, and that will manifest with pericarditis. So pericarditis can be seen in case of patient having chronic kidney disease for a long period of uremia. Not just that, as we know, the urea will also inhibit the platelet adhesion and aggregation. So urea will also aggregate platelet adhesion and aggregation, and that will result into platelet dysfunction. And it will also manifest with massive bleeding. So platelet dysfunction and bleeding can also be associated. As we also know that if there will be increased amount of urea, so this increased amount of urea will be so much that the liver cannot detoxify other ammonia because of that, and as a result of which also due to increased amount of urea, this increased amount of urea via the bacteria which are producing urease, this will manifest with increased amount of ammonia, and this increased amount of ammonia will go to the brain, and that will manifest with asterexis. So this condition is known as encephalopathy due to uremia. Not just that, we can also appreciate the urea, and this urea will be deposited into the skin in the form of crystals, and that is known as uremic frost. Not just that, this will also result into severe itching and pruritus in the skin as well. So these are all the features which are due to increased level of urea, and the symptoms are, and hence the condition is known as uremia, because there is high level of urea in the blood, and that is manifesting with clinical features that we have just mentioned. So you can see over the features that uremia may be present in chronic kidney disease, and this uremia means azotemia with the symptoms, sign and symptoms of renal failure. And what are the symptoms that we associate is that we can associate uremic gastroenteritis, and that will result into nausea, anorexia, and vomiting. As I've already said, the urea may also get deposited into the skin in the form of crystal, and that may result into pruritic skin, that is known as uremic frost. Not just that, this can also result into uremic encephalopathy, where the amount of ammonia will be increased, and this amount of ammonia, what it will do is that this ammonia will result into alpha ketoglutarate. So this, let us consider this alpha ketoglutarate in presence of ammonia will be converted into glutamate. So there will be decreased amount of alpha ketoglutarate. As we know, alpha ketoglutarate is one of the substrate for Krebs cycle. So Krebs cycle will not be functioning properly. Hence, there will be decreased amount of ATP formed. And because there is diminished amount of ATP, this will manifest with drowsiness, difficulty to concentrate as well. And as we know, the glutamate will combine with ammonia, and because it will convert into glutamine. So there, the blood levels of glutamate will also be decreased. And as we know that the glutamate is normally decarboxylated into GABA. So if there is decreased amount of glutamate, hence the GABA amount will also be decreased. And because of this will manifest with seizures, and even it can result into fatigue, coma, disorientation due to all decrease in the alpha ketoglutarate and increase in the glutamine, and that will be exchanged with serotonin as well. So this is all resulting into uremic encephalopathy as well. So the next feature that we associate with uremia is that, so as we know, the kidney function has been compromised, and the function of the kidney was to excrete the excess amount of fluid, or to get rid out of excess amount of water. So if the kidney function is compromised, there will be deficient amount of salt and water that will be excreted. Hence, the increased amount of salt and water may result into volume overload, and that may also manifest with hypertension. And hypertension can also be manifested due to activation of renin, angiotensin, aldosterone axis as well. And not just that, we know the function of the kidney is to get rid of potassium and also to get rid of hydrogen ions. If the kidney is not able to do so, there will be increased amount of potassium manifesting with hyperkalemia. So that will result into hyperkalemia, and that will manifest with metabolic acidosis, and that will also manifest with metabolic acidosis as well. So these are also features that can be associated with uremia. And the other feature that we can appreciate is that, as we know, the function of kidney has been compromised, and it is the cells lining the peritubular capillary, around the peritubular capillary, the type 1 cortical cells, which are responsible for formation of erythropoietin. And this erythropoietin, it is necessary for the RBC formation, and it will hasten the process of synthesis of RBC from the myeloid precursor cell. And if there will be decrease in erythropoietin, the amount of RBC will get decreased, and that will manifest with anemia. So we also associated other features as well. So let us discuss that as well. So we can see anemia, and this anemia is due to the decreased amount of erythropoietin hormone that is produced by kidney. And as we know, erythropoietin is required for erythropoiesis. So decreased erythropoietin means decreased erythropoiesis, and that will manifest with decreased RBCs, and that will result into anemia. Not just that, it is the function of the kidney to get rid of potassium. If the potassium is not being excreted, the level of potassium will be increased in the blood, and that will manifest with hyperkalemia, and it is all because of lack of glomerular and tubular filtration. So as the filter GFR has been decreased, so the potassium filtering will also be decreased, and eventually the level of potassium will go up in the blood. And also, as we know that, let us consider this is one cell. If there is, and also as I've said, there will be increased amount of protein as well, because protein, the way of excretion of protein is via the kidney. One of the way of excretion is via the kidney, because kidney will manage the protein. And if the protein will be high, so we know that protein will get into the cell, and eventually from the cell to maintain the electron neutrality, potassium will come out of the cell, and this will also manifest with hyperkalemia. So there will be shifting of potassium from the intracellular compartment to the extracellular compartment. It is all due to acidosis, and that may also result into hyperkalemia as well, and that we have already discussed. Also, as we said, it was the role of kidney to get rid out of excess salt and water. And as the kidney is damaged, salt and water cannot be excreted efficiently. Hence, that will manifest with fluid overload, and that can, if whenever the fluid overload is so much so, then it can also result into pulmonary edema as well. So this is also one of the complications that can be associated with the kidney failure. And not just that, it is also the role of kidney to get rid out of phosphate. So it is the role of the kidney to get rid out of the phosphate via filtration and also via decreased absorption. So it is mostly via the filtration. The body will get rid of the phosphate, and if the kidney function is compromised, the phosphate the body will be not getting rid out of phosphate, and as a result of which there will be increased amount of phosphate in the blood, manifesting with hyperphosphatemia. Not just that, the increased amount of phosphate will combine with calcium. The increased amount of phosphate will combine with free calcium, and that will result into decreased amount of free calcium, and that will result into hypocalcemia. But not just this, hypocalcemia can also be manifested due to other causes as well. As we know that it was the role of kidney to activate the vitamin D via the enzyme alpha-1 hydroxylase. As the kidney is damaged or the function of kidney has been compromised, there will be decreased activity of alpha-1 hydroxylase. Hence, vitamin D cannot be activated. Hence, the calcium cannot be mobilized from the intestine, and eventually there will be decreased amount of calcium in the blood, and that will also contribute to hypocalcemia as well. And because of this chronic hypocalcemia that happens with renal failure, this will activate the parathyroid gland, and the calcium sensing receptor in the parathyroid gland will sense that there is decreased amount of calcium. Hence, the parathyroid gland will produce parathyroid hormone for a chronic period of time. And as we know, parathyroid hormone, it will act on the bones, and it will eventually result into bone resorption. It will result into bone resorption, and it will, as the bone is being resorbed out, it will manifest with a condition that is known as osteitis fibrosa cystica. So this condition can be seen because what happens is that if patient has hypocalcemia, this will manifest with increased amount of parathyroid hormone from the gland, and this parathyroid hormone will result into increased bone resorption, and this bone resorption will result into destruction of the bone, and with the destruction of bone there will be fibrosis plus formation of cyst in the bone, and this condition is known as osteitis fibrosa cystica. Not just that, as we said, there is decreased amount of vitamin D, and also there has been decreased amount of vitamin D, and also there is increased amount of parathyroid hormone, and because of both of these conditions, this will manifest with osteomalacia. Why does it manifest with osteomalacia? It is because we cannot mineralize the osteoid from the osteoblast. So osteoblast will try to lay down the osteoid, but what happens is that because of the deficient function of vitamin D and due to increased function of parathyroid hormone, this osteoid cannot be adequately mineralized, and due to defective mineralization of the osteoid, that will manifest with osteomalacia. Not just osteomalacia, for a chronic period of time, it can also result into osteoporosis. So one might ask me, why does osteoporosis happens in this condition? So one of the reasons that I would like to give you is that when you leach the calcium from the bone over a period of time, and it can result into, so as we see in the bone, there has been loss of calcium for a chronic period of time, and along with that there has been severe activity of the parathyroid hormone. Plus, as the kidney is damaged, it is not able to get rid out of the hydrogen ion, and this hydrogen ion will also contribute to acidosis. So parathyroid hormone will activate the osteoclast cell eventually, and osteoclast cell in presence of acid will, the activity of acid phosphatase will also be activated, and this will eventually destroy the osteoid, and due to destruction of the osteoid, it will manifest with pores in the bone, and that is known as osteoporosis. It is all because of increased amount of parathyroid hormone activity along with acidosis with the removal of calcium from the bone. with the destruction of osteoid matrix, and that will manifest with osteoporosis as well. So these all features that I just discussed with hypocalcemia and hyperphosphatemia, and this condition is known as renal osteodystrophy. So now we'll be discussing about renal osteodystrophy, or also known as metabolic bone disease, and it will result into severe osteoporosis. Not just that, it can also result into osteitis fibrosa cystica, and along with that, it can also result into osteomalacia. So as I said, there is decrease in the GFR, and that will result into decreased clearance of phosphate. This will manifest with increased level of phosphate in the blood, causing hyperphosphatemia. And this hyperphosphatemia will combine with calcium, and eventually the free amount of calcium will be decreased, causing the condition known as hypocalcemia. And hypocalcium will stimulate the parathyroid gland, and parathyroid gland will activate or release parathyroid hormone, and this parathyroid hormone will result into increased bone resorption to bring the blood calcium to the normal level. And during the process, it will result into excessive calcium resorption, plus the acidic environment will also result into destruction of the osteoid due to activation of the osteoclast, and that will result into osteoporosis. And due to the pathology of the renal parenchyma, as we also know that the amount of vitamin D cannot be converted into the active form because of deficient activity of alpha 1 hydroxylase enzyme, and because due to this condition, the amount of vitamin D is low, and this causes poor absorption of calcium from the GI tract, and eventually causing hypocalcemia, and the osteoid uh, cannot be adequately calcified, resulting into osteomalacia as well. So hypocalcemia, as I said, it will stimulate the parathyroid gland, and the parathyroid gland will eventually cause more and more destruction of bone, resulting into the several features of osteodystrophy. It is also known as metabolic bone disease, as we have already discussed. So hyperphosphatemia, along with the calcium and phosphate, will try to get deposited into several tissues of the body, especially that will result into dystrophic, not dystrophic, it can result into metastatic calcification. And this metastatic calcification occur in areas having alkaline environment, because as we know that the precipitation of calcium and phosphate happens in the area where there is a lot of alkali. In the alkaline environment, when the pH is basic, this will favor the deposition of calcium and phosphate. So in what areas do we expect alkaline environment? We can expect alkaline environment in the lungs, because we should know the this reaction. So carbon dioxide usually combines with water to eventually form carbonic acid, and this carbonic acid will eventually form bicarbonate. And if we are going to puff out carbon dioxide, eventually we are going to get rid out of the acid, and eventually we are going to generate bicarbonate. And in this condition, so basically what I am trying to say that every organ which is trying to get rid out of acid in the intestine, it is trying to make the blood alkaline, because as the carbon dioxide, it is a form of acid. If it is getting out, then the intestine will be alkaline, and this happens in the lungs. So lungs will get rid out of carbon dioxide, we know. It will happen in the intestine of the kidney, because we know the kidney will also get rid out of the hydrogen ions via this enzyme carbonic anhydrase process. Not just that, it can also be appreciated in the stomach, in the intestine of stomach, because stomach is also releasing acid into the mucosa of the stomach, in the lumen of the stomach, and creating the alkaline tide that we know. So in all these conditions, the lungs, be it the be it the stomach, be it the kidney, in all this site, what happens is that there will be deposition of calcium, and this calcium deposit is known as metastatic calcification. Not just that, as I've already said, it can also result into acidosis, because hydrogen ion cannot be excreted by the kidney, and all these conditions I have already mentioned. And along with the fact that increased amount of urea will result into decrease in platelet aggregation and decrease in platelet activation, and this will be manifest with severe bleeding tendency, because increased urea level will cause platelet dysfunction as well. So in this video, we discuss a lot of information regarding the chronic kidney disease, the cause behind the chronic kidney disease, and not just about chronic kidney disease. We also discussed about benign nephrosclerosis versus malignant nephrosclerosis. So I hope you understand a lot of parameters in this video, and I hope you will go forward taking all these points. And if you did not if you did not manage to understand, you can watch the video time and again, and it will go and imprint on your brain itself. So thank you very much for your patient listening.